Okay, so let's start with the discussion of the GD of the anatomy questions. I'm Dr. Ankit. Let's start the question number 1. Which of the following is correctly related to the cubital fossa? The fossa in front of the elbow, cubital fossa. So, which is correct over here? Its lateral boundary is formed by the pro teres. Option number A. B says median nerve is present lateral to the brachial artery. Floor is formed by the supinator. Tendon of biceps is present medial to the brachial artery. Let us look at the cubital fossa, general, right? So, supposedly this is the lateral side, that is the medial side, right? Then there is a muscle coming from the lateral side, from the lateral epicondyle, upper margin of it, supracondylar, you can say. This muscle is the brachioradialis. For the medial aspect, where the muscle coming up is the pronator teres. So, this is the pronator teres, that is the brachioradialis. On the floor of it, we have a muscle over here, which causes supination, that is a supinator muscle over here. So, this muscle over here is a supinator. So, this forms the floor, and this pronator teres and the brachioradialis, they form the medial and the lateral boundaries. You can see the medial and the lateral boundaries. Then the contents over here, remember the mnemonic is MBBR, MBBR, from medial to lateral. So, most medial, you have this median nerve coming down. Then you have the pulsation of the brachial artery by which you measure the BP. So, here you have the brachial artery as well, which bifurcates into radial and ulnar artery. Then lateral to it, you have this biceps strong tendon coming down, biceps brachii tendon, which inserts into the radial tuberosity. And most laterally coming from the sides, coming from the posterior, we have this as the radial nerve. This will be the radial nerve. So, let's label it. This is the median nerve. That's the brachial artery. This is the biceps brachii tendon, and this will be the radial nerve, right? The roof of this whole cubital fossa is mainly consist of the median cubital vein, right, where we take the venous sampling. This is the basic anatomy of the cubital fossa, very important area. Let's see the options now. So, what is correct over here? Lateral boundary is formed by the pointer teres. No, it is formed by the brachioradialis. So, wrong. Median nerve is present lateral to the brachial artery. No, it is present medial to the brachial artery. Wrong. Floor is by the supinator. Correct. Option number C is correct over here. Let us see option number D as well. Tendon of biceps present medial to the brachial artery. No, it is present lateral to the brachial artery. This is also wrong. Answer therefore is our option number C. Very important topic. Roof, borders, floor, contents, everything has been asked over here. Good question. Answer is option number C. Right? Let's see the next question. What's the root value of the ulnar nerve? So that's a question directly from the brachial plexus. Brachial plexus, we all should be aware, have the root value of C5, C6, C7, C8 and T1. Right? These two, they form the upper trunk, C7 forms the middle trunk, and these two, C8, T1, they form the lower or the inferior trunk. Then all of these three trunks, they form the ventral divisions, right? Ventral, 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 and they also form the dorsal divisions, the dorsal as well as the dorsal divisions. All these dorsal divisions, they form the cord that is a posterior cord. These two ventral divisions over here, upper and middle trunk, their ventral divisions, they form the lateral cord. And the ventral division of the lower trunk, this forms the medial cord, right? Now coming to the ulnar nerve. If you look at the branches of the cord, the medial cord, the mnemonic is M4U, 4 times M and a U. This U over here represents the ulnar nerve. So, if you trace the whole cord, this medial cord over here is from the ventral division of the lower trunk, which itself is from C8 and T1. Therefore, the whole root value of the medial cord is basically our C8 and T1. Therefore, this should be the root value of the ulnar nerve. But remember over here, a better option or a slightly more, you can say, a detailed option over here for the ulnar nerve is C7, C8, T1. Now, how C7 enters over here? Now, from the lateral cord, the C7 fibers from the lateral cord, they come down over here and they meet the ulnar nerve. They will contribute to the ulnar nerve. Therefore, the exact root value of the ulnar nerve or detailed root value is this. But considering the options, we can go with C8 and T1 as well. This will be our best answer. Right. So, remember the branch of the cord. Remember from where the cords are forming. For example, over here, we can very well understand that the posterior cord is from the dorsal divisions of all the three trunks. Therefore, the posterior cord root value will be from C5 to T1 all. The lateral cord is from the ventral division of the upper and the middle trunk. So its root value will be C5, C6, C7. Understand? Middle cord we have already seen C821. Right? This will help you in not just memorizing but understanding the root values of different nerves. If you know the branches of the cord, you know the root value of the cord, you have a good idea of the root value of the branches of those cords. Right? So therefore, answer over here is option number B. A good question from the brachial plexus, a very important topic in our upper limb. Let us see the next question. Which nerve is damaged if the fracture happens at the site of the marked arrow? Which bone is this? This is the humerus bone. The bone over here is the humerus. You can see the olecranon fossa over here. You can see the medial epicondyle over here. This is which side humerus? We are looking at a posterior view of humerus. Posterior view of humerus. And this is the medial side, that's the lateral side. So this is obviously the right humerus having a posterior view. The arrow is pointing out towards the mid shaft. And over here in mid shaft, you have a groove over here which goes from medial to lateral. This groove, as we all should be knowing, this is known as the radial groove or the spiral groove because it is spiral course. This radial of the spiral groove has main two contents. So those two contents are, obviously, one is the radial nerve itself. So one over here is the radial nerve, and the second content of this groove will be the vessels. Which vessels? They will be the profunda brachii vessels. Profunda brachii vessels, the branches of the brachial artery. So the nerve that will be damaged if this fracture is in the mid shaft will be obviously the radial nerve. Let us look at the options, and option number A is therefore the answer. There can be other options, other questions as well. If the arrow points out towards here, towards the surgical neck, here the axillary nerve is the one that is mainly damaged. Understand this. If tomorrow the arrow is pointing out towards the medial epicondyle, the nerve that passes behind this is the ulnar nerve. These are three main nerves which can be damaged if there is a injury to the humerus directly. The axillary, the radial, and the ulnar nerve. Here they are asking the mid shaft, answer is radial nerve. Right? Good question. Let's see the next one. What's the action of the marked muscle in the image? Now, how to identify the muscle? Only when you identify the muscle, you can identify its action. You can see these long tendons. These are tendons of a particular muscle. These are going towards the distal phalanx. They are obviously the flexor digitorum profundus. The muscle that is coming out from the flexor digitorum profundus is the one that is labeled over here. These are the lumbricals. Lumbricals action is a pen holding position. This is the action of the lumbricals. They flex the MCP and they extend the interphalangeal joint. So the major action is that is they flex the MCP metacarpophalangeal and they extend the interphalangeal joint. Let's see the options. If we have good knowledge, we can be searching for the options. Option number A is flexion at DIP, no. Flexion at PIP, no. Abduction of fingers, no. Option number D is the correct. For other options, flexion at DIP is done by FDP tendon. Flexion at PIP is mainly by FDS, flexor digitorum superficialis tendon. Abduction of fingers is basically done by the dorsal interossei muscle, dorsal interossei, which are the bipinnate muscles. Answer is lumbricals, and tomorrow they ask you about its nerve supply. Remember over here there are 4 lumbricals. The lateral 2 lumbricals are supplied by the median nerve, and the medial 2 lumbricals are supplied by the ulnar nerve. And the damage to the lumbricals leads to clawing of hand. Right? So here they ask the action, and the action will be the flexion at the MCP, which is the answer. Let's see the next question, which is not a content of the superficial perineal space. Here they are talking of the perineum. So let's see the perineum over here. So understand how to understand this, that if suppose this is a urinary bladder, right? The male particularly, this is the prostatic urethra surrounded by the prostate gland. Below prostatic urethra, we have the small urethra that is a membranous urethra. And here you will have these muscles like sphincter urethrae and the deep transverse perineal muscle. Right? So here what we have the prostatic urethra, and here we have the membranous urethra, and these muscles are basically deep transverse perineal, and surrounding the urethra we have the sphincter urethrae acting as a external urethral sphincter. Below this, what actually happens is that we have a small membrane over here that is known as the perineal membrane. Then what happens, the urethra goes down, it becomes the bulbar urethra and then the spongy urethra, then it comes out. So here you have this part of the urethra known as the bulbar urethra, and this will be the spongy urethra. Remember, this bulbar spongy urethra, they are the anterior part of the urethra, and the prostatic membranous, they are known as the posterior urethra. Now, the point comes that this perineal membrane is the structure that actually divides the perineum into a superficial perineal space, which is over here. So this area below the perineal membrane is the superficial, because it is closer to the skin. The openings are there. Superficial perineal space or superficial perineal pouch. And the space above it is the deep perineal space. Now, if you look at the urethra in the superficial perineal space, we have a bulbar and the spongy. The muscles surrounding the bulbar urethra over here, they are the bulbospongiosus. Bulbospongiosus. Muscles on the sides, both the sides, are the ischiocavernosus. Ischiocavernosus. There is a deep transverse perineal muscle, and therefore the muscle just below the perineal membrane over here will be its counterpart, that is known as the superficial transverse perineal muscle. Right? So this gives us a good idea of the contents of the both pouches. Let us look at the option. They are asking us which is not a content of the superficial perineal space. Option number A is a content. Superficial transverse perineum is the content. Deep is present in the deep perineal pouch or deep perineal space. This is also content. Therefore, the answer is option number C. This is not present in the superficial transverse or superficial perineal pouch. It is present in the deep perineal pouch. Hence the answer. Right? Okay, let's see the next one. Lesion of the superior temporal gyrus, which is already labeled over here, leads to which of the following? The 4 types of aphasias are given over here. If you look at the brain, then this is, imagine the brain, looking at the left cerebral hemisphere. This is the temporal lobe, this is a superior temporal gyrus. The speech center over here is the Wernicke's area, also known as the sensory speech area. Sensory speech area having the Brodmann number of 22. Therefore, lesion over here will lead to a sensory aphasia. So, lesion will lead to sensory aphasia. Now, sensory aphasia meaning by the comprehension of a spoken language is lost. But they'll be fluent. There's no problem in speaking out. So, this aphasia is also known as the fluent aphasia. Same thing, right? So, if you look at the options, obviously it's straightforward Wernicke's aphasia, but other names are sensory or the fluent aphasia. Right? Broca's aphasia is present where? It's present, Broca's area is in the inferior frontal gyrus. It will present slightly higher up, somewhat over here. This is the Broca's area. That is a 44, 45 is the Brodmann number. And that is a Broca or the motor speech area. Therefore, answer over here is simply straightforward, is option number B. Which artery supplies both of these Wernicke's or the Broca's area? The artery is supplying them is the middle cerebral artery. M4 branches. Right? So, MC in fact, particularly on the left side, because these language centers are present mainly on the left side of the cerebral hemisphere. Answer is option number B. Okay, let's see the next one. Which of the following layer is termed as a dangerous area of the scalp? In the head and neck, there are few dangerous areas. For example, here they are asking scalp. The answer over here is a loose areolar tissue, which we will see in a while. But other dangerous areas are dangerous area of the face, dangerous space in the neck, dangerous area of the scalp. But these are the danger areas. We should know them. Dangerous area of the face is the central part, lower part of the nose and the upper lip. So, between the nose and the upper lip is the area, dangerous area of the face. Thrombosis might migrate from here and may lead to cavernous sinus thrombosis. Danger space of the neck. It is present between the prevertebral fascia and the alar fascia. Infections of the pus from here might percolate down into the mediastinum. Therefore, it is a dangerous layer of the neck. The dangerous part of the scalp. Now, have a look at the scalp. There are 5 layers in the scalp. This first S is for the skin. This C is for the dense connective tissue. A is for the aponeurotic layer. L over here, which is the answer, is the loose areolar layer. This P is the pericranium, which is just overlapping the skull bones. Now, why loose areolar is the dangerous layer? Because there are various emissary veins over here which directly go down via diploid veins. They might interact with the meningeal veins or the dural venous sinus. They might lead to meningitis over there. So, infection of the scalp If it is present in the loose areolar layer, via emissary veins, the thrombus might enter into the inside the skull. Therefore, this is the dangerous layer of the scalp. Answer is option number B over here. Okay, right. Let's see the next one. Which is the unpaired cartilage of the larynx? Larynx we know has 9 cartilages, in which 3 are paired are 3 number, and unpaired are also 3 number. Obviously, the unpaired are supposed to be in the center, and therefore here unpaired names are epiglottis, thyroid cartilage, and cricoid cartilage. Paired ones are the 3, they are the arytenoid, then the corniculate and the cuneiform. So they are asking you which is unpaired. Unpaired are these 3. So cricoid is unpaired, yes. Corniculate, no. Epiglottis, yes. Arytenoid, no. Cuneiform, no. Answer is 1 and 3. If you look at the options below, 1 and 3 is option number C over here. These are the unpaired cartilages of the larynx, right? So remember, unpaired and paired cartilages of the larynx total are 9 number. A recent question came out the hyoid bone. Hyoid bone is not a part of larynx. Okay, right. So let's see the next one. Which of the following is not a content of which sinus? A cavernous sinus. Now, if you understand that middle cranial fossa had this sella turcica, right? Below you have this sphenoid air sinuses, and this gap is known as sella turcica. It is housing what? It is housing the pituitary gland, and over which what we have the diaphragm and sali over here. Around this, you have a couple of sinuses, dilated venous sinuses. These are the ones which are known as the cavernous sinus. Now, if you look at the cavernous sinus, then on the lateral walls, you have 3-4 nerves over here, which are the 3rd nerve, the 4th nerve, and the 1st division of the trigeminal, that is ophthalmic. Inside the cavernous sinus, you have one other nerve, that is the 6th or the abducens nerve over here. This is the 6th or the abducens nerve over here. So they are present both the sides, 3rd nerve, 4th nerve, V1 and abducens nerve. Also inside the cavernous sinus, you have a very huge vessel, that is the internal carotid artery 2. Right? Now you should know the basic anatomy of this. V2 might also be present, that is the maxillary division. It might or might not. It might be over here, it might be slightly lateral to it. But we know this basic idea. So if you look at the options, cranial nerve 4 is present, yes, it is present. 3 is present, 6 is present, yes, 7 is not present. 7 is not related to the cavernous sinus at all. So in cases of cavernous sinus thrombosis, which is quite frequently asked, in cases of cavernous sinus thrombosis, there will be problem in the nerve 3, 4, 6, V1. So there will be ophthalmoplegia, there will be pain in the eye, but there won't be any facial muscle features because 7th nerve is not related at all with the cavernous sinus, right? So remember, option number D will be our answer. Actually, what happens is cranial nerve number 7 and 8, they directly go to the internal acoustic meatus because they have to reach the area of the ear, inner and the middle ear. They don't go to the cavernous sinus, right? Let's see the next one. Which is not endodermal, So out of 4, 3 must be endodermal, 1 should not be endodermal. Let's see the options. Thymus. It is coming from the 3rd pharyngeal pouch. All the pharyngeal pouches are endodermal. So it is thyroid. It is also endodermal. Parathyroid, that is also endodermal, coming from the 3rd and the 4th pharyngeal pouch. Obviously, you are left with option number D. That should be the answer without looking what it is. But yes, that is the answer. Adrenal cortex is derived from the mesoderm, basically the intermediate mesoderm, hence the answer. Adrenal cortex, mesoderm, adrenal medulla is neural crest cell. So if they ask you tomorrow about the adrenal medulla, don't forget it is a neural crest cell which is a part of ectoderm, neuroectoderm. That is also not endoderm, right? So ABC are coming from endoderm, not the option number D. Hence the answer is option number D. Physiological constrictions in esophagus are found at all the given levels except. We should know that the normal length of esophagus is around 25 centimeter. Right? So what happens actually is, above we have this area known as the oral cavity, then we have this pharynx and all, and then we have the beginning of the esophagus which goes down, and finally it will pass through what? Pass through this diaphragm, and then a couple of centimeters, then it becomes what? Becomes the stomach over here. So total length of esophagus is around 25 centimeters. So there are a few constrictions over here. What are those? First constriction is when it starts, beginning of it, that is at the cricopharyngeal junction, right? Then what actually happens is there is this arch of aorta going out. It compresses. Then apart from this, there is left bronchus. They are very close. So you have this structures as second constriction known as bronchoaortic constrictions. Third major constriction is when it passes through the opening of the diaphragm, that is around which level? At T10 level at the diaphragm. So these are the major constrictions. If you insert a Ryle's tube, you should know their levels as well. So around 15 to 18 centimeter, you get this first constriction. Around 22, 24 centimeter, you get this second constriction. Around 40 centimeter, you get this third constriction. Then after 1 or 2 centimeter, you enter into the stomach. Now let's see the options. Diaphragm, yes, there is a constriction. Thyroid gland, no. Thyroid gland has no, because thyroid gland is present in front of trachea, right? And yes, thyroid gland will not compress. Normally, it doesn't compress the esophagus. Let us see other options as well. Arch of aorta, yes, bronchoaortic and pharyngoesophageal junction. This cricopharyngeal is same as pharyngoesophageal junction, the beginning. So therefore, option B is our best answer. Because in front of esophagus, we have the trachea. In front of trachea, we have the thyroid gland, right? The thyroid gland normally does not constrict. If the thyroid gland enlarges pathologically, then it might cover the trachea, it might go behind, compress the esophagus. Then there will be dysphagia, meaning by compression of the esophagus, but not normally, right? Therefore, physiological is not thyroid, it is pathological constriction, but others are physiological constriction. Answer is option number B, right? Let's move to the next one. Muscle attached to the arrow marked bony structure. If you look at this image, the arrow is marking towards a point coming from the upper medial part of the femur. What is this? This, remember, this is the femur, so this outer part is the greater trochanter, and this point over here is the lesser trochanter. Lesser trochanter. The muscle attached over here are the iliopsoas, that is iliacus and psoas major. And these two muscles are the major flexors of the hip joint. Supplied by the lumbar plexus, and the action is major flexors of the hip joint. Therefore, that should be the answer. If you search, the first option goes on to like this. The gluteus maximus, on the other hand, is attached to two places. It is attached to the iliotibial tract, the 3/4 of it, and the 1/4 goes to the gluteal tuberosity, which is present on the posterior aspect of the femur. The gluteus medius is attached to the greater trochanter, not the lesser one, and the sartorius arises from the anterior suprailiac spine, goes down into the medial condyle of tibia. So therefore, obviously not over here. Answer is option number A, iliopsoas. It is for this reason, do remember that in case of psoas abscess, there can be swelling in the groin region, right? Let's see the next one. Okay, a 65-year-old male arrives at the frequent and hesitant urination. DRE indicates enlarged prostate. Biopsy is conducted to determine the underlying histological composition of the prostate. Microscopic analysis reveals a distinct stromal component surrounds the glandular epithelium. What makes the prostate stroma? So question is just the last line. The rest all is just to increase the length of the question. The question is only the last line. What makes the prostate stroma? The prostate stroma, you should know, is always fibromuscular. It's quite a hard structure. If you might have seen it in dissections or in pathology specimens, you should know that it is quite a hard structure. And the stroma in prostate is mainly fibromuscular stroma. Therefore, answer is our simply straight option number D. Do remember this point. Prostate is a fibromuscular glandular stroma is what we call as a normal prostate. In this case also, the stroma will be fibromuscular, right? Let's see the next one. A cricket bat struck a 48-year-old man in the mid region of the arm, mid part of the humerus, right? The clinical assessment reveals an inability to extend the wrist, that is, there is wrist drop, and sensory loss in a small area of skin on the dorsum of the hand. There's sensory loss between the first two fingers. This is first and second finger. The first two fingers over here, there's some sensory loss. Here, there's some sensory loss, and there's wrist drop. What nerve supplies the particular area of the hand? Wrist drop itself says it is something related to radial nerve or its branch. Could be the posterior interosseous nerve as well. But the sensory loss over here is due to the superficial branch of the radial nerve. So it's all revolving around one nerve, which is the radial nerve. That should be our answer. If they have given the radial, that is the answer. If they would have given the superficial branch of radial, that would have been a better answer. But in that case, also radial nerve is a good enough option, right? So radial nerve. Remember the cutaneous innervation of the hand. On the palmar aspect, we have the median nerve and the ulnar nerve. Median 3.5, ulnar 1.5 digits. If we go dorsally, the ulnar nerve continues on this part also, supplying around 2 to 2.5 digits over here, and the lateral part, the one that was asked in the question, this is the radial nerve over here. So radial, ulnar and median. Just remember this, and therefore option number C, radial nerve, will be our best answer over here. Other options don't fit. Posterior interosseous is a pure motor nerve. Medial cutaneous branch of the forearm and lateral cutaneous branch of the forearm, they are not telling us that supply is going to the dorsum of the hand. Answer is option number C. Let's see another one over here. The spinal cord ends at what level? This is the point. In adults, we know that this spinal cord ends at the lower part of the L1 or L2. It can reach the body of L2 as well. But in a newborn or infant, it reaches the lower border of, L3 is the answer over here. Lower part of the L3. Therefore, while doing a lumbar puncture in an infant or a newborn, you have to be more cautious. Because normally we do lumbar puncture in adult around L4. Does it mean L4, L5 or L3, L4? But here you have to be more cautious in a newborn child because the spinal cord length is slightly more. It is not that the spinal cord is more lengthy, it is that the vertebral column has not yet gained its normal length. Therefore, after birth, the length of the vertebral column speeds up more than the length of the spinal cord. Therefore, spinal cord slightly ascends up to a couple of more vertebrae. Right? Therefore, in a newborn, do remember the answer is always option number D, that is lower border of the L3, right? Okay, let's see the other one over here. Which epithelium is present in fallopian tube? A histological question. Do remember epithelium are there as a functional histology. There has to be some function around it. Fallopian tube, what is the function? It has some transmit of the spermatozoa as well as the secondary oocyte. So therefore, there should be cilia present over there. Cilia. Also, there are a lot of secretions, so they are columnar epithelium. So cilia and columnar epithelium are found in fallopian tube. Let us see what are the options over here. Pseudostratified epithelium, no simple squamous, no ciliated. Yes, absolutely correct. Option number C will be our best answer over here. Pseudostratified ciliated columnar epithelium is found in the respiratory epithelium. Simple squamous is what you see in the endothelium. Simple cuboidal is what you see in the thyroid gland as well as the convoluted tubules of the kidneys. That is, there is where you see the cuboidal epithelium, or in the ducts, right? This minor ducts, salivary ducts, you see the cuboidal epithelium. Fallopian tube, ciliated columnar epithelium, right? That's even more, that all are included in the boundaries of epiploic foramen, except, we should know, very, very important topic, epiploic foramen. If you look over here, then this is the, say, the esophagus and the stomach over here, right? The duodenum over here, okay? And imagine this is the liver. So you slightly retracted the liver. And then you have this peritoneal fold going from the lesser curvature of the stomach, first part of duodenum, to the liver. And what is this known as? This is famously known as the lesser omentum. Lesser omentum. This is the right margin of the lesser omentum. This over is the right margin of lesser omentum. Now what happens is that if you can insert your finger behind the right margin, so your finger can go inside, right? And this area over here, if you try to zoom it, this area over here is what is known as the epiploic foramen. Epiploic foramen, or the foramen of Winslow, right? Now what will be the boundaries of it? Now see, what lies in front, anterior to the epiploic foramen, is the right margin of lesser omentum. The right margin of lesser omentum has the portal triad structures, which are what? Which are the portal vein, then you have the hepatic artery, and you have the common bile duct. These are present anteriorly. Behind what lies to the epiploic foramen is the inferior vena cava as well as the vertebral level of T12. Plus, you can also have a bit of right adrenal gland too. What lies superior to the epiploic foramen is a part of liver, that is the caudate process of liver. And what lies below inferiorly is the first part of duodenum. These are the boundaries of epiploic foramen. So they are asking you what is not present in the boundary of epiploic foramen. Portal vein and hepatic artery, yes, they are present anteriorly. IVC is present posteriorly. Pancreas, no. Duodenum, yes, inferiorly. So obviously the answer here now becomes option number C, pancreas. Right? This will be the answer over here. Okay? Right. Fine. So these are the questions. I hope you answered them well. If not, then see what was wrong over there, what you missed out, and all the best for the exams. Thank you.
Hello, good evening everyone, good evening students, and how was the test? Let me see your comments. I hope you liked the physiology questions. I am Dr. Anupama Chaudhary Devgan and I will be discussing the physio questions with you. So yes, never give up. Hello. That's yes. Good evening, never give up. Never give up. That's a good name. All right. And Anil, good evening. Yes. And welcome to this session. So let's start right away. Yes. Are we all ready? Farheen, good evening. Yes. Dr. Soni, I am good. And how are you? All right. So we can start with our first question. Our first question is a very important topic, which is the distribution of body water and the measurement of different body fluid compartments. Now, the measurement of different body fluid compartments is done by what is known as the dye dilution technique, right? Dye dilution technique. Yes. And this is also known as the principle of volume distribution. And what is the formula for measurement of different body fluid compartments? V is equal to Q minus E over C. What is V? V is the volume that you have to determine. Q is the known quantity of the dye which is used. E is the amount of dye metabolized or excreted during the procedure. And what is C? C is the concentration of dye in a sample withdrawn after mixing has taken place. So V is equal to Q minus E over C. Now, what is used for different body fluid compartments? Deuterium oxide is used for the measurement of total body water. Inulin is used for the measurement of ECF. Evans blue is used for the measurement of plasma volume. Antipyrine is used for the measurement of total body water, right? Antipyrine is also known as aminopyrine. Right? So the answer to this question, measurement of ECF is done by, my answer to this question becomes B, and that is inulin. For ECF volume, which are the dyes which are going to be used? Inulin is the one which gives the most accurate measurement. We can also use sucrose, we can use mannitol, we can use radioactive sodium. Right? So these are the substances which can be used for the measurement of ECF volume. Yes, absolutely correct. Avinash, Vinod, you have got your answer correct. Never give up. No, Evans blue is for plasma volume. This is for the ECF volume. These are the substances which are used for ECF volume. Siddharth Sharma, Evans blue is for plasma. Anil Soni for plasma. Never give up. Evans blue is for plasma, right? So this answer is inulin. So just briefly, for total body water, what are we going to use? We will use deuterium oxide, which is also known as heavy water. We can use tritium oxide, and we can use aminopyrine. For ECF, I have already told you, inulin, mannitol, sucrose and radioactive sodium. For plasma volume, we can use Evans blue, or we can also use what is known as radioactive iodine labeled albumin. For the measurement of intracellular fluid and interstitial fluid, these are both indirect measurements. For intracellular fluid, total body water minus the ECF. For interstitial fluid, ECF minus plasma. Right? So this is how we are going to use, how we are going to measure the different body fluid compartments. But please remember, the substances used for measurement of different body fluid compartments are different, but the formula is the same. Which is the formula? We know that already. That is your V is equal to Q minus E over C. Remember, intracellular fluid, interstitial fluid start with an I. These are both indirect measurements, right? Indirect. ICF, total body water minus ECF, and ISF, ECF minus plasma. All right, so this is as far as your different substances are concerned. All right. Okay, so let's go on to the next question. Now this says, in nerve injury, retrograde degeneration. Retrograde degeneration is seen in. So basically we're looking at Wallerian degeneration, right? And now what are the changes which are going to happen once there is a nerve injury? Now we know that the three types of nerve injuries are neuropraxia, exontemesis and neurontemesis. Now, you must understand that Wallerian degeneration is not seen in neuropraxia. Neuropraxia is a temporary disruption of function, but degeneration will be seen in exontemesis and neurontemesis. What is the major difference between exontemesis and neurontemesis? In exontemesis, in both we will see degeneration, yes, but in exontemesis, neurilemma is intact. What is neurilemma? Neurilemma is the outermost layer of the Schwann cell, right? So neurilemma is intact in exontemesis, and whereas neurilemma is destroyed in neurontemesis. Neurilemma is also destroyed. So regeneration will only be seen in exontemesis, not in neurontemesis. So regeneration will be present in exontemesis, will be absent in neurontemesis. So this is the major difference. Yes. Now, as far as degeneration is concerned, let me just give you the sequence. And again, this is a question which has been asked. And that is, now, for instance, if this is a neuron, a multipolar neuron, these are the dendrites, right? And here is the myelin. Outermost layer of the Schwann cell is known as neurilemma. So let's say if there is a cut injury, let's say there is a cut injury like this. Yes? Now what are the changes that we are going to see? The changes can be divided into changes in the cell body. Now within the first 24 to 48 hours after the injury, we find there is what is known as chromatolysis. Chromatolysis. What is chromatolysis? Now remember, in the cell body, you have what are known as Nissel's granules. Nissel's granules are nothing but ribosomes and mRNA. Chromatolysis is disappearance of the Nissel's granules. Chromatolysis, disappearance of these colored granules or the Nissel's granules. Yes. Now, this is in fact the first change to occur. This is a question which has been asked, which is the first change to occur, that is chromatolysis, right? Now, there are changes in the distal segment and changes in the proximal segment. Distal segment means distal to the injury, proximal to the injury. Now, in the cell body, one more change, the nucleus moves to the periphery. Nucleus, which has a central position, moves to the periphery. Now, let us see what are the changes in the distal segment. Changes in the distal segment. Within the first 3 to 5 days, you have axonal degeneration. The axon will swell up, it will start breaking down into smaller rodlets, they are called, right? And so axonal degeneration will occur in the first 3 to 5 days. On the 8th day, the myelin degeneration will start. Myelin begins to degenerate. Again, it will break down into lipid droplets. And on the 32nd day, myelin degeneration is complete. 8th day, the myelin degeneration starts and it is complete by the 32nd day. Now, the same changes will also be seen in the proximal segment. Whatever I have described in the distal segment will be seen in the proximal segment, but up to the nearest node of Ranvier from the site of injury, right? Same changes as in the distal segment. As in the distal segment, but up to the nearest node of Ranvier, right? So this is how you're going to describe the changes. Changes in the cell body, chromatolysis, and nucleus starts moving to the periphery. Distal segment, first, so remember, 1 day chromatolysis, first week axonal degeneration. After 1 week, myelin degeneration starts. After 1 month, myelin degeneration is complete. Now, once the axon has degenerated, myelin has degenerated, macrophages are your scavengers. They enter and they will remove all the debris. Whatever has been broken down will be removed by the macrophages. So, at the end of 1 month, you will get what is known as a ghost tube. What is ghost tube? It is an empty tube of neurilemma. Right? So this is the sequence of events which are going to happen as far as your degeneration is concerned. Once again, first day chromatolysis, first week axonal degeneration. After 1 week, myelin degeneration starts. After 1 month, myelin degeneration is complete. Right? So this is the sequence. Now let's see what was the question. It says retrograde degeneration is seen in. What is retrograde degeneration? This will be in the proximal end. But please remember, the degeneration which is seen in the proximal end will be up to the nearest node of Ranvier from the site of injury. In the distal segment, the complete distal segment will degenerate, but in the proximal segment, up to the nearest node of Ranvier from the site of injury, right? So, Vinod Kumawat, Yogi Mahendra, Vinod has got it right. He said B, Yogi is saying A. No. Distal segment is the anterograde, ahead, isn't it? So that will be, distal segment will be the anterograde degeneration. Is that clear? Is the sequence of events clear? This is a commonly asked question. It has been asked a few times, and I want you to have the sequence absolutely clear in your mind. What is the sequence of events? First change to occur will be chromatolysis. Is that okay? Is everybody okay with this? Can I move on to the next one? All right, let's see true about local potential. It is always depolarizing. True about local potential. Local potentials are the result of a sub-threshold stimulus. If the stimulus is threshold or supra-threshold, it will give rise to an action potential, but a sub-threshold stimulus will give rise to a local potential. Yes. Now, is it always depolarizing? No. It can be depolarizing or it can be a hyperpolarizing potential. A depolarizing local potential is known as an EPSP, excitatory postsynaptic potential. A hyperpolarizing local potential is known as an IPSP, inhibitory postsynaptic potential. It follows all or none phenomena? No. All or none is action potential. Local potential is a graded response. What do I mean by a graded response? If the stimulus is small, small change. If it is a larger stimulus, larger change. But if the stimulus becomes threshold, then you will get an action potential. Action potential follows a all or none law. Depolarization till the threshold potential is a must for local potential to occur? No. Depolarization till threshold potential is a must for the action potential to occur. So this also becomes an incorrect statement. Magnitude of local potential decreases with an increase in distance from the site of stimulus. This is true. So my answer to this question is D. Right? This is local potentials are decremental. And what you mean by decremental is that is, the magnitude of the local potential will decrease with an increase in distance from the site of stimulation. So my answer to this question is D. Anil has got it right. Prajwal, Vinod Kumawat, never give up. Have you? I hope you've been able to understand where you've made a mistake. Right? Please remember, C is not the answer here because depolarization till the threshold potential is a must for action potential, not for a local potential. See, once the potential of the cell reaches threshold potential, then opening of sodium channels is by a positive feedback mechanism. Then you will definitely get an action potential. Have you understood? But local potentials, they are produced by subthreshold stimuli, they are decremental responses, graded responses, they can be depolarizing or hyperpolarizing. Let's go on to the next question. Which of the following has the fastest velocity of conduction? Now here you have the fastest velocity will be seen in the Purkinje fibers. Purkinje fibers. The speed of velocity in the case of Purkinje fibers is 4 meters per second. For SA node and the AV node, this is 0.05 meters per second. For bundle of his, it is 1 meters per second. So the fastest velocity of conduction will be in the Purkinje fibers. Absolutely right, Fareen Sultana. Never give up. Dr. Anil Soni, Prajwal, excellent. This is absolutely the correct answer. Okay, let's see the next one. The next is, which of the following is a true statement relating to the baroreceptor reflex, right? Now, as far as the baroreceptor reflex is concerned, it is activated when the blood pressure falls below 50. No, this is false. Please remember the threshold for activation. The threshold for activation of the baroreceptors is a mean arterial pressure. This is a mean arterial pressure of 50 millimeters of mercury. Below 50, there is going to be no response. The threshold is 50. Older knowledge was that the threshold is 60. But today we know that the threshold is 50. Below 50, they will not show a response. So this becomes an incorrect statement. B, option B says, it causes a decreased parasympathetic response to an increase in BP? No. This is also a false statement, because what happens if there is an increase in BP? The reflex response is a decrease in sympathetic and increase in parasympathetic. So parasympathetic outflow increases. If there's an increase in BP, sympathetic response will decrease and parasympathetic will increase, right? So this also becomes a false statement. It is an example of positive feedback. This is also false. This is an example of negative feedback. Please remember, negative feedback mechanisms are stabilizing. They help to maintain homeostasis. What is homeostasis? Maintenance of nearly constant conditions in the internal environment. So this is an example of negative feedback. Sensory or the afferent fibers from the baroreceptors join the 9th and the 10th cranial nerves. This is true. So my answer to this question is D, right? So let me see. Dr. Anil Soni says it increases parasympathetic, negative feedback. Option D is right. Excellent. That is absolutely right. Remember, when the baroreceptors are excited, sympathetic response reduces and parasympathetic increases, right? Remember, baroreceptors are brakes for BP. What do I mean by that? Brakes for BP. BP पर brake लगा देंगे. That is, if there is an increase in BP, baroreceptors will reduce the sympathetic discharge to lower the blood pressure. It is a brake for BP. गाड़ी चल रही है, brake लग गई. Have you got it? So this is your, by decreasing the sympathetic discharge. All right, let's look at the next question. First heart sound is heard at the onset of which of the following phases of the cardiac cycle? So first heart sound is, Darshan says, explain negative feedback. Darshan, let me take it towards the end of discussion of these questions. I will just remind me, I will discuss what is negative feedback. All right. Now, first heart sound is heard at the onset of which of the following phases of the cardiac cycle? Now, remember, first heart sound is due to closure of the atrioventricular valves. Mitral valve on the left side, tricuspid valve on the right side. And this is the onset of ventricular systole. Onset of ventricular systole, right? So, onset of ventricular systole has got 3 phases. Isovolumetric contraction phase, phase of rapid ejection, and phase of slow ejection. These are the phases of ventricular systole. So S1 will be heard at the onset of isovolumetric contraction. Remember, isovolumetric relaxation, rapid filling phase, atrial systole, these all happen in ventricular diastole, right? And S1 is heard at the closure of the mitral and tricuspid valve. Yes, Prajwal. Right. Okay. Right. So this will be at the onset of isovolumetric contraction phase. Sorry? Dr. Anil says closure of the tricuspid and the mitral and the tricuspid valves, atrioventricular valves. This is heard at the, this is due to closure of the AV valves. AV valves are mitral and the tricuspid valve. Is it okay? All right. Second heart sound is due to closure of the semilunar valves, that is aortic and pulmonary. Okay. Between S1 and S2 is ventricular systole. So S2 will be heard at the onset of isovolumetric relaxation phase. All right, let's go on to the next one. Which of the following receptors is responsible for Which of the following receptors respond to a change in texture? Now, here this is Meissner's corpuscles. Meissner's corpuscles are your a little more detail about the mucinous corpuscles. Mucinous corpuscles, these are very rapidly adapting receptors, right? They are very rapidly adapting touch receptors, right? And where are these mucinous corpuscles located? They are located, so this is the skin, this is the epidermis and the dermis. Dermis projects into the epidermis. It has these finger-like projections which are called dermal pegs. And what is located in the dermal pegs is this elongated encapsulated receptor, and this is known as the mucinous corpuscle. Please remember, where is the mucinous corpuscle located? This is located in mucinous corpuscle is located in glabrous skin. What is glabrous skin? Glabrous means non-hairy skin. Non-hairy skin means palms, soles, lips, right? And these mucinous corpuscles are especially abundant in the lips, nipples, fingertips. These are the areas where you see plenty of mucinous corpuscles. Plenty of mucinous corpuscles will be seen, right? These are especially abundant over here. And what are the mucinous corpuscles meant for? They are meant for fine touch. They are meant for slow vibration. They are meant for texture. Topognosis. What is topognosis? Gnosis is detection, topo is surface. When you want to feel a surface, you use your fingertips, and fingertips have got plenty of mucinous corpuscles. So topognosis and braille. Braille is a script which is for the blind, for the visually challenged. There are elevations and depressions, and how do they read is by running their fingertips on that special paper. So mucinous corpuscles are specially meant for that. So these are some important. Also, which is the nerve fiber associated with mucinous corpuscle? This is A beta. Nociceptors are meant for pain. Pacinian corpuscle is meant for fast vibration and for deep pressure. Fast vibration and deep pressure. Ruffini's corpuscles have got similar functions as mucinous, but Ruffini's corpuscles are present on hairy as well as glabrous skin. What are Ruffini's corpuscles or Ruffini's discs meant for? Fine touch, texture, topognosis, right? But for all these, your better answer is mucinous. All right. So let me see what is Gokul saying. Gokul says, so A, I think everybody answered A. Anil, Ramesh, Vinod said A. Gokul said braille, absolutely right. Anil Soni, sensation for fine touch and slow vibrations. Yes. And yes, less than 80 per second. All right. And cutaneous nerve endings are responsible for pain. Yes, absolutely. Absolutely correct. Okay, let's go on to the next question. Which of the following is not a cause of the left shift of the oxygen hemoglobin dissociation curve? Now, what are the causes for left shift? Now, whenever the curve shifts to the left, there is a decrease in P50 and an increase in affinity. And how do I remember that? FAL. Favors affinity, shift to left. Favors affinity, favors association. Rightward shift, we say FDR, favors delivery, disassociation, shift to right. Left shift, FAL, favors association or affinity, shift to left. Now, what are the conditions which cause a shift to left? If there is a decrease in PCO2, if there is a decrease in H plus or an increase in pH, a decrease in temperature, a decrease in 2,3-BPG, hemoglobin F and myoglobin, and also in banked blood. So increase in CO2, PCO2 causes a right shift. Increase in pH will cause a left shift. So the answer to this question is B, right? Oh, sorry. Which of the following is not a cause? Sorry. Okay. Let me just go with the options once again. Increase in PCO2, right shift. Increase of pH, left shift. Decrease of temperature, left shift. Decrease in 2,3-BPG, left shift. So what is not a cause will be an increase in PCO2. Are you okay with that? No, all three, the others are yes. Never give up says A, which is absolutely right. Yes, all the others, these three options will cause a left shift. Increase in PCO2 causes a right shift. Okay with that? Has everybody got it? Yes, 2,3-BPG is a byproduct of the glycolytic pathway. 2,3-BPG and oxygen bind on the same place on the beta chain, right? So if there is more 2,3-BPG, less binding with oxygen, less 2,3-BPG, more binding with oxygen. Less 2,3-BPG, left shift of the curve. Is it okay? All right. Let's go on to the next one. Which of the following statements is correct? NREM sleep is characterized by vivid dreaming. That is incorrect. It is the REM sleep. When I say vivid dreaming means dreams that he can recall. NREM sleep, there are dreams, but we cannot remember them. In REM, we are able to recall. So that is why they are called vivid dreams. Vivid is also, vivid means clear. You know, this is what he can recall. NREM sleep approximately accounts for 20 to 25% of the sleep time. This is an incorrect statement. REM sleep accounts for about 25% of the sleep time. It's about 50% in a newborn baby. As we grow older, the amount of time spent in REM sleep reduces. So in adults, it's about 25%. In the elderly, it reduces to about 15%. So NREM is characterized by a decreased heart rate, decreased blood pressure, decreased respiratory rate. This is a true statement, right? REM sleep, the heart rate, blood pressure, the respiratory rate, they become irregular. REM sleep is a period of autonomic instability. Autonomic instability. But in NREM is known as a restful sleep. Why do we call it a restful sleep? This because during this time, heart rate, respiratory rate, blood pressure will all show a decrease. Now, NREM sleep is also known as deep sleep. Now, this is almost a true statement. Why I say true statement is, now if I have to choose between C and D, which is more correct for NREM sleep, I will go for C. Why not D? Now remember, NREM stages 3 and 4 are typically described as deep sleep, right? So a slight, it's like, you know, when you have to make a choice between, like I said, option C and D are both correct for NREM sleep, but a little more detail. It is the stages 3 and 4. Which are known as deep sleep. So a slightly better answer will become C, right? Yes, Anil says REM sleep, 20 to 25% of sleep time, vivid dreaming, REM sleep, heart rate, blood pressure, respiratory rate become irregular. This is a period of autonomic instability. I don't know if you can correlate sometimes, you know, sometimes when you are, supposing you are woken up when you were dreaming, generally it is associated with palpitations and there are irregular heartbeats, right? Sometimes, I don't know whether you've ever been woken up in REM sleep, and that is when you're, especially when you are in a particular dream, and suddenly and when you get up, you are aware of your heartbeat. Yes, so that is typically seen in REM sleep. Convinced? Is everybody convinced that the better answer here is C? Is it okay? All right. Let's go on to the next question. A patient with a hemoglobin HbA1c of 11.4%, so obviously this is very poor control, has come to your clinic with severe pain in their feet at night. Which nerve fibers are involved in this patient? Now, there is a neuropathy here, which is very common. This is your diabetic neuropathy. We can get a hint. The HbA1c is 11.5%, very poor control. So the nerve fibers get affected. And which nerve fibers will be involved in this patient? C. C are your pain fibers. Pain fibers are your C fibers. He's complaining of severe pain in their feet at night. So the answer will be C. For pain, the free nerve endings are the receptors for pain of the type C fiber. Type C is the smallest diameter unmyelinated fiber. So this is the one which has got affected. All right. Question number 11. Which of the following is correct regarding the physiology of the PCT? PCT reabsorbs 100% of the filtered glucose. This is a true statement. Filtered glucose as well as amino acids. 100% are going to be reabsorbed in the PCT itself. It is impermeable to water. This is a false statement. It is very much permeable to water. In fact, 2/3 of the water is reabsorbed in the PCT, right? No amino acids are reabsorbed in the PCT. False. 100% of filtered amino acids will be reabsorbed in the PCT. PCT is the site of action of aldosterone. False again. Aldosterone acts on the collecting duct. So answer to this question is going to be PCT. PCT reabsorbs. The question says which is correct. So A is going to be correct. Absolutely right. Never give up. Gokul, Avinash. Yes, Anil, Farhina. Answer is A. Absolutely correct. Let's go on to the next question. Question number 12, it says a 50-year-old male presents to the doctor for a 6-month checkup following diuretic therapy and recommended dietary changes for his essential hypertension. His BP is 140/95, his serum aldosterone is elevated. Aldosterone secretion is increased due to a decrease in which of the following in this patient? Right? Aldosterone secretion is increased due to a decrease. So increase in renin increases aldosterone. Renin-angiotensin aldosterone system. Increase in renin causes an increase in angiotensin. Angiotensin will increase the aldosterone. So both of these are not the answer. ACTH. What happens if there is increase in ACTH? Now, ACTH, you must understand, though it does not directly control aldosterone secretion, but yes, ACTH increases steroidogenesis. So it can cause an increase in aldosterone. So please remember, not directly. It's only because it increases the steroidogenesis. That means it increases the utilization of cholesterol to form the steroid hormones. That is basically mainly cortisol, androgens, but also to some extent aldosterone. Though please remember, it does not directly cause increase in aldosterone secretion. But if there is a condition where there is elevated ACTH secretion, then you will get increased aldosterone as well. A decrease in sodium will increase. Decrease in sodium is associated with decrease in ECF volume, which increases renin, which will increase angiotensin 2, which will increase the aldosterone. So my answer to this question is D. Just like Avinash, Chandan, you have got it correct. Answer to this question is D. Decrease in sodium will increase aldosterone secretion. Okay, excellent. Let's go on to the next one. Which of the following thalamic nuclei receive input from the basal ganglia? And cerebellum and project to the motor cortex. Now basically, when we are talking about motor cortex, we want to know which are the motor nuclei of the thalamus. The motor nuclei of the thalamus are venteroanterior and venterolateral. These are the motor nuclei of the thalamus. Ventroposterolateral, this is a sensory. It is meant for somatic sensations. Anterior thalamic nucleus is involved in memory. It is a part of the Papez circuit, which is involved in memory. Midline and intralaminar, these are non-specific. So answer to my question number 13 is A. Okay, so everybody seems to have got it correct. Anil, Gokul, Bhavani, Mithu, yes, A. These are your motor nuclei of the thalamus. Let's look at the next question. Question number 14. Which of the following is not required to measure creatinine clearance? How am I going to measure creatinine clearance? The general formula for clearance is UV by P. So urinary creatinine into rate of urine flow divided by plasma creatinine concentration. So I need urinary creatinine. Yes. I need plasma or serum creatinine. Yes. I need volume of plasma passing through the kidney in 24 hours. No. I need volume of urine produced in 24 hours because this will give me rate of urine flow. What is rate of urine flow? That is V. This is rate of urine flow is in ml per minute. In 24 hours, this is the amount of urine produced. In 1 minute, how much is the urine? So what I do not need is volume of plasma passing through the kidney in 24 hours. So absolutely right. Anil Soni C, Farhina C, Bhavani C, and Chandan also C. Correct. Let's go on to the next question. A wave of JVP occurs in which of the following phases of the cardiac cycle? Now, A wave of JVP is due to atrial contraction. This is due to atrial systole. And atrial systole is responsible for the second rapid filling phase. So my answer to this question becomes D. This is second rapid filling phase is due to atrial contraction, and atrial contraction will result in a positive wave on the JVP, which is known as the A wave, right? In the isovolumetric contraction phase, you get the C wave of JVP. What is C wave? This is the bulging of closed tricuspid valve into the right atrium during isovolumetric contraction. In the ejection phase, you get the X descent. In the first rapid filling phase, you get the Y descent. The second rapid filling phase, which is due to atrial systole, the answer is A wave, right? So absolutely right, Dr. Anil Soni, yes, A wave generated by atrial contraction, not arterial contamination. Yes, I know, this is all autocorrect, so we can yes, we can ignore that, right? Okay. All right. Yes, C wave is due to, it's a positive wave which is due to, okay. C wave is due to bulging of the closed tricuspid valve into the right atrium during isovolumetric contraction phase. Fantastic. Okay, let's go on to the next question. It says, a 20-year-old student, college student, presents to the emergency with sudden onset of severe epigastric pain that radiates to the back. He's a chronic alcoholic, pain radiating to the back. As you can make out, this is probably pancreatitis. He's a chronic alcoholic. Another hint, the organ involved in this patient's pathology under normal physiological conditions is stimulated by a hormone secreted by the duodenum in response to acidic chyme present in the lumen. What effect does this hormone have when it stimulates the organ of interest? So whenever there is acidic chyme which is present in the duodenum, it will cause the secretion of a hormone which will cause the secretion of a alkaline rich pancreatic juice, right? Alkaline rich pancreatic juice, and that is going to be secretin. Secretin, it is stimulated by a hormone secreted by the duodenum. So S cells in the duodenum give rise or secrete what is known as secretin. Secretin will increase the bicarbonate content in bile and pancreatic juice. Avinash and Anil, you have to listen, you have to read the question carefully. It says, what effect does this hormone have when it stimulates the pancreas, right? Though the clinical scenario was of pancreatitis, but here the question asked is a physiology question, that hormone secreted by the duodenum acts on the pancreas. So secretin is secreted by the S cells of the duodenum, and it increases the bicarbonate content in bile and pancreatic juice. All right, Mithu is absolutely right. This is C. Let's go on to the last question. The last question is, all of the following are central controllers increasing appetite except. Now, what are the options that have been given? MCH. This is what is MCH? MCH is your melanin concentrating hormone. This increases appetite. Orexin increases appetite. Neuropeptide Y increases appetite, but GLP-1 decreases appetite. Remember, appetite is control or hunger. The hypothalamic hormone which controls hunger is lateral hypothalamus. What produces satiety is ventromedial hypothalamus. So these hormones, MCH, orexin, neuropeptide Y, they will act on the lateral hypothalamus and increase appetite. GLP-1, this is secreted by the beta cells of pancreas. Sorry, glucagon-like peptide 1, sorry. This is secreted by the L cells in the small intestine. This produces satiety, right? GLP-1. Right. Now, just to remember which are the ones which increase appetite, remember Goa men. G, ghrelin. O, orexin. A, agouti-related peptide. M, MCH. E, endorphin or endocannabinoids or endocannabinoids. N is neuropeptide Y. So remember the a little mnemonic, remember Goa men. Goa men increase appetite, yes, and G, ghrelin, orexin, agouti-related peptide, MCH, endocannabinoids, and neuropeptide Y. GLP-1 is going to produce a decrease in appetite, right? So this is as far as your the physiology questions is concerned, right? I'll give you my email ID, that is Dr. Anupama Devgan at gmail.com. And any questions, any queries regarding today's test paper or any other queries regarding physiology, please feel free to get in touch with me. My Facebook page is Dr. Anupama's Physiology. You can also send me a message on Messenger, and I will try and sort out any doubts that you might have, right? Thank you so much for your participation. Thank you so much for being a very receptive audience and for participating in the questions. See, physiology is a highly doable subject, high yield subject, a little bit of effort, and you will be able to do all your physiology questions. Concentrate a little bit on physiology, and like I said, this is a high yield subject. You should be able to score almost 80 to even 100% in physiology. So thank you very much, and all the best, and God bless. Thank you, Avinash, Mithu, Farina. Thank you. Fareen, sorry. Fareen, never give up. Thank you very much.
Hello dear students, myself Dr. Amit Jain, and now we'll continue with the session of biochemistry. So hope you had a wonderful session of anatomy and physiology. Right, so let's start with the question number 1. Okay, am I audible, visible? Fine. So let's start with the question number 1. So which of the following enzyme is deficient in Her's disease? Okay, HER, Her's disease. So that is the enzyme that is, guys, deficient in the type 6 glycogen storage disorder, right? Okay, so I think this is one of the topic that you all have mastered already, right? That is glycogen storage disorders. And I would suggest you one thing यार कि मतलब एंजाइम तो आना ही चाहिए. अगर आप बायोकेम पढ़ रहे हो तो सबसे इम्पॉर्टेंट चीज़ है एंजाइम. एग्जामिनर हमेशा एंजाइम ही पूछेगा, भले वो NEXT पैटर्न एग्जाम हो या USMLE पैटर्न हो या FMG पैटर्न हो, कोई भी हो, ठीक है. तो सबसे पहले वो जानना चाहता है कि भाई तुम्हें एंजाइम याद है कि नहीं है. इफ़ यू रिमेंबर द एंजाइम, दैट इज़ द बेस्ट थिंग दैट यू कैन डू, राइट. So yes, definitely the answer is correct. Never give up. Okay, yes. So answer is B. Correct answer, right? So glucose 6 phosphatase. So type 1 disorder, right? Type 1 disorder is the disorder that is called as the von Gurki's disease disorder, and the enzyme is glucose 6 phosphatase. Type 2 is Pompey's disease, right? Pompey's, and Pompey's affects the heart, right? Also remember Pompey's affects the heart. So what's the name of enzyme? Lysosomal acid maltase, right? It is lysosomal acid maltase. That's the name of the enzyme. Type 3 is the Cory's disorder, right? So ABCD, Anderson branching, Cory's debranching, right? Fourth is Anderson, that is branching, right? So Anderson branching, Cory's debranching, that we all know, okay? And yes, correct, if it is hepatic. H for hexa also, right? If I say that is hexa, type 6, okay, hexa means hepatic phosphorylase or the liver phosphorylase. And type 5 is the muscle phosphorylase. Clear? Okay, let's move. So this is a very important topic and must do topic for any exam. Okay, so looking at the question number 2, given pictures signify the deficiency of which vitamin, as in the option. So which vitamin is deficient here? So there's a vitamin deficiency, it is clear here, right? Out of the 3 picture, the best picture that you can remember always is this one, right? The second one. Okay, so that is the cut at the angle of the mouth, and that is called as angular stomatitis. So guys, riboflavin deficiency present with, okay, so that's a riboflavin deficiency, and riboflavin deficiency present with what? It presents with the 3, that is triad, okay? It's present with the triad of, okay, triad of number 1, angular stomatitis, number 2, circumcorneal neovascularization, that is the new blood vessels around the cornea, and number 3, that is glossitis or the magenta colored tongue, though it is not shown here as magenta, but yes, the color is magenta colored tongue, right? As you read a lot of other, colors like strawberry tongue or something else. Clear, guys? Okay, so answer is vitamin B2. Okay, no, Pratik, not C, it's riboflavin. Okay, so looking at the option 1, we have beriberi, that is riboflavin, that is thiamine presents with the beriberi. Okay, and looking at, and also thiamine presents with lactic acidosis. Don't forget this, very important. Thiamine also present with the thiamine deficiency, I mean to say, present with lactic acidosis. B12 deficiency, if we talk, definitely it's megaloblastic anemia, and we have a question also in the last. So megaloblastic anemia, and on the skin there is, there is a pigmentation or the hyperpigmentation of the knuckles, right? That is very important. And B5 is pantothenic acid, 5 for, the foot or the, let's say, your hands. So 5 for burning feet syndrome, clear? So that is your option D, right? So guys, what is the answer? Question number 2, answer is B, right? Fine. Which of the following glucose transporter helps in insulin mediated, glucose uptake? So guys, remember one thing, that the type 4 is the answer, right? that is GLUT4. GLUT4 is the answer here. Okay, remember like this. If we try to remember, we can remember like this. Okay, mad or foreigners, right? Okay, what I'm writing is foreigners actually. So 4 is insulin dependent and MAD is muscle including heart and adipose tissue, right? Muscles and adipose tissue. So MAD foreigners. So GLUT4, most important one. Plus please don't forget the heart. Heart is also a muscle, right? Okay, and heart is dependent on insulin mediated glucose transport, though we all know that heart is not utilizing glucose normally. In the routine metabolism, the heart utilizes 80% fatty acid, right? We should also know that what are the sources of energy in the fasting and fat state. Okay, that is an important question. And heart always prefer fatty acid, whether it is a fasting state or the fat state. That is almost 80%. So 20% only it is dependent on glucose, right? Okay, fine guys. So that is GLUT4. And also remember GLUT1, that is present in RBC and blood-brain barrier. Okay, and what is special about GLUT2? It is beta cells of pancreas and liver. And guys, in the liver it is bidirectional, means it can take glucose, it can give glucose. Correct? Okay, so that is your question number 3. Fine. Question number 4. Osteogenesis imperfecta is a disease of the collagen, right? So which collagen is deficient? So what is your answer? Yeah, GLUT5 is fructose, good. So what is your answer here? That is osteogenesis imperfecta affects the bone obviously, and bone has, right? So when I say bone, that is 1, okay, type 1 collagen. Guys, one more thing which was a recent MCQ, right, in the exam, and that was like fibrocartilage, right? Fibrocartilage. That is also the type 1 collagen. Don't forget this, because as soon as we see cartilage word, we think of collagen type 2. So type 2 collagen is definitely, it is present in cartilage. Type 3 collagen is, present in extracellular matrix, right? And type 4 for the floor, right? I can remember 2 as a cartilage. Like for example, if I write cartilage, so cartilage has type 2, but fibrocartilage has mostly type 1, right? It has type 2, but mostly type 1. If there is a MCQ, I have to mark type 1. Don't forget that. Okay. Then cartilage, type 3, and 4 for the floor, right? Just to remember, floor means like basement membrane. Okay. So that is basement membrane. Clear to all? Fine. So that is your, yes. Dr. Anil Soni, not ECF, that is ECM. Okay, fine. So that is question number 4, done. Then moving to the question number 5, which is very easy, right? You might have done it very correct, because all the mothers, all the females are transferring the genes to all the child. So disease is transferred to all the kids, right? As you can see, this female or mother has given the disease to all the 4 kids. Similarly, this female has given the disease to all the 3 kids, right? Okay, so that's a mitochondrial disorder, right? Okay, mitochondrial disorder. So guys, what are the examples of mitochondrial disorders? We don't have to remember a long list. Guys, remember just few names, okay? And the one of the most important name is MELAS, okay? Mitochondrial encephalopathy, lactic acidosis, and stroke, right? So MELAS is due to defective type 1 and type 4. That was one of the question also, that ETC complex type 1 and type 4 are affected in MELAS, right? Okay, then there are a lot of other names, okay, of the mitochondrial disorders. Like for example, if I say first is MELAS, then other is Can and Sire syndrome, okay. Okay. Then Leber's hereditary optic neuropathy, fine. And one more name that is called as LEIGH, Leigh syndrome, right? Leigh syndrome. Okay, just remember like Melee में Kern and Saira, Kern the name, loan लेने गए थे, right? Loan लेने गए थे, ठीक है? Just remember. So Leigh's disease, Lone is LHON, Leber's hereditary optic neuropathy. Clear, guys? So that's how you can remember it. That is, okay, very good, Dr. Anil Soni. Okay, so that is all. Guys, remember Rett syndrome as one of the very important example of X-linked dominant disease. Okay, right, this is one of the disorder which is X-linked dominant disorder. Very, very important. Very frequently asked question that which of the following is the example of X-linked dominant disorder. So you can mark RETT Rett syndrome. Clear? Okay. Moving to the next question, Huntington's disease involves a trinucleotide repeat of. So guys, trinucleotide, like in the DNA, you know, if a repeat of the 3 set of, you know, bases is repeated, so 3 makes 1 genetic code. So we can get what is the problem? We can get multiple amino acid repeated, suppose CAG, 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 like that. Okay, so that is your Huntington's disease, and CAG codes for, let's say, glutamine, and you know, there will be again lots of you know, the extensive glutamine repeats will be there, like that. So that is a trinucleotide repeat. Fine, guys. So there are a lot of other disorder, like this is myotonic dystrophy, second number. Then CGG is the Fragile X syndrome, and GAA is Friedreich's ataxia. So Fragile X, Friedreich's ataxia, that is C and D. Fragile X, C, and D is the, what is D? D is the Friedreich's ataxia. Okay, and B is myotonic dystrophy. Okay, myotonic dystrophy, Fragile X syndrome, and Friedreich's ataxia. So guys, these are the important names that we should always remember, right, in the disorders. Okay, gray vial is used for, so guys, this is the one of the very easy one, and the answer for this question is definitely the glucose, right? Okay, and for CBC we generally use the lavender or the purple one with EDTA, and for the coagulation profile like PT and INR, we use the blue one. Okay, so that is purple or the lavender one, and ESR, right, we can use the black one, right? So guys, apart from this, the gray vial is also used for the blood alcohol, lactic acid estimation also. Don't forget this, right? Don't forget that if you want to analyze the blood alcohol level, what is the vial that we should ideally use? Answer is gray vial. Ideally, this is the ideal situation, like, you know, though we don't use the black vial for ESR, but that is the ideal one. But okay, fine. So guys, please don't forget this line, question number 7. Yeah, correct, EDTA. Fine, guys, is it clear? Any question you have? Okay, so moving to our next question. Guys, in this question, as an image is given, and it's a bilateral, you know, Achilles tendon xanthoma. So this is almost certain of the diagnosis of type 2 hyperlipidemia, right? Type 2 hyperlipidemia is, you know, because of, so that is the answer, type 2 hyperlipidemia, or we also call it familial hypercholesterolemia. As you can see in this question, they have also given the cholesterol is very high, and the TG is normal, right? Okay, LDL is very high, HDL is normal. Okay, HDL doesn't go high, right? Most of the time it is in the lower side. In most of the cases of other disorders like Tanger's and fish eye disease, HDL becomes low. LDL becomes high in case of type 2 hyperlipidemia, and that is what we called as familial hypercholesterolemia. Am I clear? Okay, so that is the type 2 disorder. Guys, again, just to repeat, you know, in the type 1 disorder, you know, there is a deficiency of lipoprotein lipase, and there is increase in the levels of TG. So what is the deficient? Lipoprotein lipase. In type 2, there is a deficiency of LDL receptors, and there is increase in mostly cholesterol. TG is normal. In type 3 disorder, you know, there is ApoE2 expression is there, and there is increase in both TG and cholesterol, and that is, you know, same amount, almost same levels, like 300 TG cholesterol. Okay, and looking at the clinical picture, type 1 patient has, you know, the plasma contains milk. I mean to say milky plasma. It looks like a milky plasma. Okay, type 2 is shown in the picture, and type 3, There is palmar xanthoma. You know, these creases, they become yellow. That is called as a palm xanthoma. Okay, in the type 3, palm xanthoma is certain almost diagnostic of type 3 disorder. Right, guys? Okay. Moving to the question number 9. Serotonin is, so answer is 5-hydroxytryptamine. This is the product of tryptophan. Right, we all know. And guys, the second is also the product of tryptophan, that is melatonin. Okay, melatonin. So that is N-acetyl 5-methoxytryptamine. To convert serotonin to melatonin, we need acetyl-CoA and the SAM, right? Okay, so SAM is also required, that is S-adenosylmethionine. So when I want to convert serotonin to melatonin, I need acetyl coenzyme A and I need S-adenosylmethionine as a methyl donor. SAM is the donor, right? Okay, guys, the option C is vitamin D and option D is not, significant here, right, guys? So question number 9. Question number 10. Keshan's cardiomyopathy is caused by, guys, Keshan's disease is because of the deficient, as you all know, right, that is selenium. Okay, this was previously a disorder seen in the Chinese population because they have a low selenium levels in their soil, but it has been also found to be associated with Coxsackie B virus, right, apart from selenium deficient states, right. So selenium deficiency and Coxsackie B virus infection has been associated with the Keshan's cardiomyopathy, right. Okay, that is a selenium deficiency. Fine. Then zinc deficiency, acrodermatitis enteropathica and hypogonadism and loss of taste sensation, that is hypojuicia, right. Copper deficiency, Menkes disease, right, not the Wilson, please don't write Wilson, Menkes, M-E-N-K-E, Menkes disease. Chromium deficiency is not actually seen, but chromium is a part of glucose tolerance factor, right, glucose tolerance factor. So chromium is the part of that. Okay, so that is like, increasing the insulin sensitivity. So that is why chromium has been tried in the treatment of diabetes also, right. Okay, guys, ठीक है. सुन रहे सब लोग? Glutathione decrease किस में? Not glutathione, selenium dependent enzymes are glutathione peroxidase. Okay, so that is antioxidant enzyme, an antioxidant enzyme that will decrease. Okay, that was a question in FMGE exam recently also, selenium dependent enzymes. So that is glutathione peroxidase definitely. Then there are two others, that is deiodinase is very important. Deiodinase that converts T4 to T3, right, guys? Okay, some question on genetics. MUTYH gene, okay, or we can also call this MYH gene, is associated with, so guys, the answer is base excision repair, and if it is defective, this leads to, MUTYH associated polyposis. So MUTYH associated, P for polyposis. Okay, so polyps in the intestine will form and they increase the risk of, lifetime risk of GI cancers or the colon cancers, right. So base excision repair disorders are not very commonly found in the humans. Currently they are not much identified, right. Okay, like base excision means, when the A binds with the U in the DNA. So this U is wrong, right, because it is found in RNA, not in the DNA. But presence of U will not affect much, right. As per the current data, like lots of disorders are, there are no disorders linked with base excision repair in humans except this one. So remember this one, not a common question till now, but yes, you should know, right. Nucleotide excision repair disorders is xeroderma pigmentosum. DNA mismatch repair is hereditary non-polyposis colon cancer. Homologous recombination disorders are familial cancers. Okay, so BRCA1 and 2, that is familial breast and ovarian cancer, right. Okay, and if it is non-homologous and joining related disorder, remember at least SCID, disorder of non-homologous and joining, that is SCID, severe combined immunodeficiency. Homologous recombination disorders are familial breast and ovarian cancer. This is hereditary non-polyposis colon cancer for mismatch repair, and xeroderma pigmentosum for nucleotide excision repair. So guys, all 5 points that I told you, all are important, right? Okay, fine, because these are disorders linked with DNA repair, right? Okay. Which of the following is rate limiting enzyme for glycogenolysis? So guys, the answer for this question is phosphorylase, and it is also dependent on vitamin B6. So what is the coenzyme for that? Vitamin B6. And glycogen synthase for glycogen synthesis. This is glycogenolysis, that is breakdown of glycogen. Okay. Fine. Okay, moving to our next question. So guys, looking at this physical finding, as you can see, this is the pigmentation here, right, because of accumulation of the homogentisic acid, right? So what's the name of this disease? This is a case of alkaptonuria, right, where there is a pigmentation, dark pigmentation of the various cartilaginous tissues like sclera, and the ear cartilage is one of the common one, right? So what is the answer for this question? Definitely you know that this is a case of alkaptonuria. Tyrosinase deficiency causes albinism, right? Fumarate acetoacetate hydrolase deficiency causes tyrosinemia type 1, right? And cystathionine beta synthase deficiency causes homocystinuria. Clear? तो यार ये सब याद रखना हमें, ठीक है? Because again I am telling you, most important is pictures जो हमने पढ़ी है revision session और classes में भी, and the names of enzymes, right? Okay. So guys, that is all about question number 13. Question number 14. Ketone bodies can be utilized by all of the following organs except. Okay. So except, the answer for this question is definitely the RBCs, because ketone body utilization occurs in mitochondria and RBCs have no mitochondria, right? Guys, remember this. And guys, one more thing that you should always remember is liver also. Liver can make ketones but cannot use ketones, right? It cannot use ketones. So that we should always remember. Okay. Brain, guys, remember one thing that can be important is that, after the 2 week of fasting, that is almost a prolonged fasting, 70% energy, okay, from ketone bodies, right? 70% energy from the ketone bodies, right guys? So that is your answer. Question 14b. Fine. Yes. So guys, please, my point is, like, what I want to tell you is that it's not the hi-fi things that examiner wish to ask. Most of the time the examiner is asking very basic things, and that all depends on our revision, right? How much we have revised, because in the end, if we perform a simple question wrong, that gives us what we can say is the negative marking, or what we can say is the less markings, the desired marks. Fine. Moving to our next question, complex 2 in the ETC. See guys, complex 2. See, complex 1 is rotinone. Okay, so rotinone, it also has a 1. Complex 2, fine, it is malonate and carboxyl, right? So that is malonate and carboxyl. So answer is D, and also the carboxyl. Complex 3 is British anti-leucite and anti-mycin. Okay, right. And complex 4 is cyanide and coenzyme, cyanide and carbon monoxide and azide, right? These are the 3, and H2S also, and finally the H2S. So these are the most important inhibitors. Again, I am repeating, in our revision book also, right, for the ATS that you have seen, I have given a table which has all the list of inhibitors. Inhibitors are very important, right? Vitamins are very important, and disorders are very important. And if I give you the sequence, like first, you should know all the inhibitors, because that's a very small topic and you can cover them easily. All the inhibitors in biochem, that's hardly 15 to 17 names, right? You have to remember. Second is all the vitamins and their disorders and their function, everything about vitamins that is in your notes, right? That is the second most important question. And third is the disorders, right? So if you master these three topics, right, definitely disorders are little bigger, they take little more time, but these two initial topics takes no time, right, hardly 2 hours. Okay, you can master them, right guys? So just stick to them. Fine. So complex 1, 2, 3 and 4, these are the names of the ETC complexes. FOF1 is inhibited by oligomycin, that is ATP synthase. Nitrogen waste, answer is urea. Okay, so what is the answer? Urea. Even uric acid contains the nitrogen substance, right, nitrogenous compound, that is uric acid is a purine derivative. So that also has nitrogen, no doubt, but the best answer will be always urea, even if it has a uric acid in the option, right? So that is your question number 16. Okay. Then question number 17. So a female patient came to the OPD with a history of fatigue, pallor and the pure, so that's not the history, but the patient was pure vegetarian, right? Okay, fine. Now doctor ordered the complete blood count and morphological evaluation of the RBC shows megaloblastic anemia, right? Okay, hemoglobin was low, serum shows high homocysteine and high methylmalonic acid. So guys, the hint is definitely one is a pure vegetarian. So pure vegetarian people are deficient in vitamin B12, right? High homocysteine and high methylmalonic acid. Okay, so because of the B12 deficiency, that is our answer. That is a C is the answer, not the B. C is the correct answer, right? So because of the B12 deficiency, see how to identify. If it is B12 deficiency, there is increase in homocysteine and there is increase in methylmalonic acid. If it's a folate deficiency, right, let's take folate here, then there is increase in homocysteine, yes, but there is a normal methylmalonic acid. So this you have to remember, right? This is for B12 and this is F for the folate. You getting my point? Okay, high homocysteine and high methylmalonic acid, answer B12 deficiency. High homocysteine but methylmalonic acid is unaffected and given the question also, right, in the question paper also. So that means they are asking that what is the difference between folate and B12 deficiency looking at the biochemical parameters. Definitely megaloblastic, you can mark both folate and B12. So it is not D here, that's not the answer. C is the correct answer. Clear guys? So that's it. Fine. Thank you so much guys, and all the best, I would say, right? All the best for your exams. Do well and let me know, right? Okay. So all the best. Thank you so much, and keep asking any questions if you have. You can find me on Facebook with the same name, Amit Jain, Dr. Amit Jain, right? And if you have any question, you can DM me on the messenger. Thank you. Bye-bye. Good night.